Well, good morning, everyone, and welcome to Cardiology Grand Rounds. We have a treat this morning. Dr. Steve Little will be our Grand Round speaker. Dr. Little does not need an introduction for this group, but I think it's important to go back through the history of Dr. Little. You know, he's Canadian, nothing against that, but actually we were fortunate to be able to have him on board for the past almost 10 years now. He did his medical school training at McMaster University, did internal medicine and cardiology at the University of Western Ontario in Canada, was interested in imaging in addition to cardiology, and did a fellowship in imaging and echocardiography in Canada. And I had the fortune actually to meet with him and bring him over as a cardiology fellow for research, advanced research in echocardiography at that time, particularly looking at 3D echocardiography. And that was in the Baylor days and Bentab days. And he distinguished himself with interest, obviously, in valvular heart disease and 3D. And even at that early stage, was able, and we're fortunate to have him collaborate and put together a hemodynamic laboratory to test various hemodynamic situations. Went back to Canada, and it took me some time to convince him to come back to the United States, and that was almost 10 years ago. And Steve has done an amazing job over the past 10 years. He is associate professor of medicine at this time at Weill Cornell and in the DeBakey Heart and Vascular Center. He has distinguished himself by focusing on imaging, and particularly in valvular heart disease, combining tools and technologies to try to understand further valvular heart disease. We're fortunate to have him actually lead and start a valvular clinic. The first valvular symposium, and it was so strategic because obviously with all the interest in valvular heart disease, catheter-based technologies, we were really ready to launch all the interventional areas in valvular heart disease. He has a laboratory now. He called it the CHILL laboratory, which is the hemodynamic laboratory where valves can be tested in addition to so many other things hemodynamically that's compatible with echocardiography as well as MRI, which is really unique. His interest as of late has been 3D printing, and actually we're among the first to publish something about 3D printing in the heart, particularly in valvular heart disease and aortic stenosis. He's involved nationally at the American Society of Echocardiography, the Society for Valve Disease. He's on the board of the American Society of Echocardiography, and really is a rising star. So without further ado, help me welcome Dr. Little to the podium.
Thank you, Bill. Very kind words. Thank you, Dr. Zogby. All right, everybody, good morning. Nice to see some familiar faces. So this is kind of a fun story. Going to give you a little overview of cardiovascular 3D printing, some of the activity that we've been involved in, some stuff that other people have been involved in, and try to keep it focused on some cases to keep you all interested. Okay, so rapid prototyping, stereolithography, 3D printing, they all basically mean the same thing. And what it means is that you can take a complex structure, and if you have a digital version of it, you can send that to a printer. The printer says, okay, I'm going to print layer 1 of whatever material you want, print layer 2, layer 3, layer 4, and just like a standard printer that goes back and forth with ink, this goes back and forth over the same geography and builds up a structure. So typically you have to have a support structure as you create something complex, and in this sort of stiletto heel, you can see this sort of architecture at the bottom. But initially this was solid, and then the stuff you didn't need was either melted away or dissolved away. So it starts as a solid, you get rid of what you don't need, and then you end up with this complex structure. Now, one of the neat things, 3D printing has been around more than 20 years, but it's really getting into medicine in the last 5 years. One of the reasons it's becoming sort of a medical technique that we need to know about is the ability to blend materials. So you can blend up to 3 different materials into one print. Those materials can be rubbery, hard, you can use ceramics, metals, stainless steel, copper and bronze. So it's really incredible what this has done. Certainly in fabrication and in other sort of industrial technologies, they're very familiar with 3D printing. But we don't print stiletto heels. We print things that look like this. And this is a heart. And I'll come back to this one in a second. So how it works, basically this is a picture of a 3D printer. This is basically, this sort of the multi-head with spraying out whatever material we tell it to spray out. In this case, we're building up a heart model. There's all kinds of different technologies, but at the end of the day, you can blend materials. There's no limit in the complexity of the geometry of what you want to make. And really the art is in deciding what materials to use, testing those materials, and coming up with novel ways to use this ability to help us clinically. Okay, so let's keep going here. So in general, why do we need models? When you have a new device, a new iteration, whether it's a valve or a plug or a stent or anything, we start with bench testing and fatigue testing. You make sure the thing does what you think it's going to do. Typically, the next step is animal studies for feasibility. There's obviously cost and ethical concerns with that. Often they're criticized on the relevance. There are no pigs that have calcific aortic stenosis, for example. So you can have animal studies, but they they often don't have really the disease that you're trying to replicate. You get into human studies basically for safety at first, cost concerns, ethical concerns, cash concerns, and then finally bigger human studies for efficacy. And then you go and change your device. You discovered something different. You make an iterative change, and you start over again. And that's why it takes years and hundreds of millions of dollars to bring a device through and change it. So an alternative really is to create anatomic models. You could couple those models to flow conditions, and now you've got a control, it's reproducible, and it's really very cheap, a cheap arena to make mistakes in innovation. So 50 years ago, this is the cover of Life magazine, and I know some of our fellows don't even know what Life magazine is. If you're north of 40, you know what Life magazine is. But basically, this was the cover, Spare Parts for People, and inside is a nice story, article about William Akers, who was at Rice University, and he had what they called sort of a heartbeat simulator at the time, and he's got a stethoscope and a bunch of tubes, and he's putting blood, or mock blood, across prosthetic valves. And he would sort of drop the balls across, and this sort of represents a different series of prosthetic valves at the time. Ball cage valves, disc valves, looking at the flow characteristics, just visualizing through the glass, along with his stethoscope. So that's sort of where it started 50 years ago in sort of simulating flows in a model. Well, so Dr. Zogby alluded to sort of circa 2005, when I was here as a fellow, we created this. This was a little mock heart. Early days of 3D echo, we were looking at mitral regurgitation and flow convergence and sort of discovering what are the limits of 3D echo. And that carried us through and was very productive for us, but we kept sort of trying to improve the model, make it more and more realistic. A few years later, a bit of fast forwarding, now we've got cardiac MRI. The entire model is MR compatible. This is a mechanical valve. We're using now 4D flow. Images are better, the model is better. So this is sort of an early study where we simply looked at the ability of a 4D flow MRI to quantitate the flow and compare it to a known transducer and say how accurate is it. So this is sort of just an example of sort of how we were marching these models forward and trying to make them better. Then we sort of took a step and we said, well, we want to model more of the complexity of like the mitral valve. So these are actually porcine mitral valve leaflets sewn into a pulsatile model. So on the images is normal. This is a normal valve sort of pulsing. What we did is we adjusted a papillary muscle on the bottom to create prolapse. And if you look up here, this entire scallop is prolapsing. And we also wanted to make functional MR. So for that, we tethered the cords, we pulled them hard, we flattened the annulus, and you can see that the leaflets don't coapt and the valve's going to pull apart. So kind of a very general approach to trying to make more and more complicated models. But in this effort, we realized we had to sort of move beyond what a machinist could make for us. We've been using a machinist, taking blocks of plastic, chopping them, trying to cord them out with drills and that sort of thing, but we wanted to get a little more complicated. We wanted to have pulmonary veins that would split, kind of like what happens in a human. We wanted to have the geometry of an atrial chamber that wasn't necessarily cylindrical. And then we wanted to get even more sort of legitimate in the mitral valve, and we wanted to have a saddle-shaped mitral annulus. So we got to that, and we said, well, we can't do this with a machinist. I've heard about this stuff, 3D printing. Really, with Steve Igo's help, we sort of said, well, let's explore this a bit. We found a 3D printer in Houston, and we started. That was our sort of first foray into let's get a little more physiologic. Let's get a little more complicated with the geometry and print things. So this got us into our initial step into 3D printing. It was really just trying to make our models better. So that's sort of the background, and this is what I'm going to focus on for the next few minutes, is really 4 major categories of cardiovascular 3D print applications. So we've got anatomic teach tools, we've got functional flow modeling, we've got procedural planning, and device innovation. The anatomic teaching is really straightforward. So this is a 3D printed heart of a patient that we have in Valve Clinic. She was one of our first CoreValve patients, so this was a CT taken 5 years ago. The pink in this model represents the calcification. So this is looking from the outside. You can sort of see through the model, the hard plastic. The pink is the calcification. This is her atrial appendage. We've chopped off the top of the left atrium, and we're looking down on the calcium that's around her mitral valve. So that's kind of a 5-year-ago model. What we have in these boxes, and I wanted to bring some demos because I have them, and they're sitting in my office, and I thought I'd share them with you. We'll pass this around. So this is a more recent 3D printed heart. So this is 1-to-1. This is based on a CT. You know what? We can just pass it around. I got 2 of these. They're robust. Don't throw them at each other, but... So this is real simple. The pink stuff, you see left ventricle, right ventricle. We made the myocardium clear so you can see the blood pool inside. And that's just a teach tool. We're not using that for anything other than understanding anatomy, demonstrating what a 3D printed model can do. But when you show something like this to a patient and you say, this is why you're short of breath, all of this pink stuff is your calcium around your mitral valve. This is why we can't do this procedure, or we could do this procedure. It's because of this. Now, you can do similar things with the generic models that you can buy on eBay, but none of them have your patient's pathology. So that's the attraction of a patient-specific model. It's got their problem. They understand it. Their families get it. If there's a language barrier, it's very simple. You show them the model, you point at the bad thing. So it does help in clinic. Functional flow modeling is really something that we got involved in quite early, and other centers, I'd say, are catching up. But this is how it works. So you take a CT. In this case, we'll focus in on the aortic valve. You can decide within the CT what's the blood pool. So this is LV. This is ascending aorta. This is flow. The pink stuff is the flow that's coming through the aortic valve. You take that volume of data into you export it to another software. And within this other software, you reconstruct just the areas you're interested in. You take away the lungs, the bone, the ribs, the vasculature you don't care about. And you can add in some plumbing elements if you want. And then at the end of the day, while you're in there, you have to say, well, this is, on a CT, this is bright white. I know that's calcium. This stuff is not bright white. That's got tissue quality. And then you have to decide what materials are we going to use to try to recreate this anatomy. And that's what we do here. So, and this is a 3D print, and you see the yellow is the calcification. This is a better sort of zoom view. So the CT close-up view of a calcific aortic valve, the white is the calcium. You take that into a digital environment. You say, well, the calcium, let's make that yellow. You 3D print it, blending, in this case, 2 materials, a hard calcium-like material, a softer, more distensible material. And you can actually take your model, you can do a CAT scan of your model, you can overlay the model's CAT scan with the patient's CAT scan and see how accurate did you really reproduce the geometry. And we've done it, and we get within a square millimeter. I mean, it's very precise in terms of recreating something static like a calcific aortic valve. The material properties, we don't test those. We partner with people at Rice, so Jane Grandy Allen at Rice Bioengineering across the street. We basically said we want to be in the ballpark. We don't know exactly the material properties of an 80-year-old aorta, because nobody does. That stuff is not published. You can find the material properties of a pig aorta, but the spectrum of pathology and material properties of people is very hard to come by. So you approximate. This is really just an example of how we test the calcium. We just basically do these calcific compression tests. For the more distensible portions, we pull it, called a tensile test. And you can compare your samples with what is available in the literature and see that you're fairly close. And that's really, for a first approximation, what we're trying to do. Ultimately, we take these models and we put them back in this flow loop that we've talked about. One of the plans was to do a TAVR within the model. this is kind of what that looks like. So this is now one of these patient-specific models pulsing. And if you've been in the OR and you've looked at an aorta or touched an aorta after they've opened the chest, it looks kind of like that. You can actually feel it, you touch it, you feel the pulse going through. It's quite distensible despite having these calcium nodules. So in terms of the gross replication, it looks pretty good. You can take the entire thing, put it in an MR scanner. You can look at the flow in more complex ways. For example, let's see here. There we go. So in CMR, with 4D CMR, you can really display the flows in quite beautiful ways, looking at streamlines, path lines, particles, velocity fields. Looks a little like computational flow dynamics, except the difference here is we know exactly the geometry because we printed it. We have all of the flow characteristics. We know exactly the pressure drop, the flow rate. So it's sort of a tool to, if you want, validate a CFD model. We haven't really had the bandwidth to pursue this in detail yet, but it's sort of one of the things we want to do as soon as we have a robust clinical 4D CMR program. We want to sort of revisit this. What we did do was take one of these models, and this is it here. So this one's not quite as robust. It's got a tricky case. But I'll leave it here, and you can all, let's go ahead and pass it around. It's pretty tough. So this is a model of aortic stenosis. So what we do is basically push flow in here, stick an ultrasound probe. Here we chopped off the apex. It's kind of got a squishy bottom so ultrasound can get through. But the aortic stenosis is right here, and this is exactly the patient's geometry. And we've stuck cameras down here, and you compare it to the CT, and it's pretty good. So aortic stenosis really lends itself to this because the valve isn't moving. It's a static snapshot. That's what a CT is. You take one time point, you print that time point. It works for aortic stenosis because things aren't moving. When we do that, here's an example. Here's the patient's echo. That's the calcification from a long axis. This is the Doppler profile, and this is the echo of the model. You see, you replicate the calcium, and you replicate the flow profile. It looks easy on this slide. It takes a lot of twiddling and fiddling with the loop to get the hemodynamics right, but with a bit of work, you can replicate aortic stenosis for the patient. So we did this for 8 patients, made models for all of them, and looked at the valve area derived by either Gorlin or Doppler, sort of shown in these little boxes here, and we compared that to the patient's clinical echo, because the patient only had one flow rate on their echo, and sort of said, well, how do they compare? And it's interesting, across 8 different patients, what we got from this was, yes, you can replicate the flow. Gorlin and Doppler methods equate pretty well. But one of the things that's interesting is, for example, patient 1, you increase the flow rate in our loop system, and the valve area doesn't really change. It varies between 0.6 and 0.7. So relatively independent. The area is relatively fixed no matter how much flow you put through. Contrast, patient 7, the more flow you put in, the bigger the valve area gets. So that's kind of contrary to our teaching. We think it's a fixed disease, more flow doesn't do it, what's going on? And then when we look back at the 3D prints and you look at the shape of the orifice, if it's really symmetrically calcified and the hole is a circle, no matter how much flow you put through, a circle can't really get bigger. So that's fixed. That's patient 1. In contrast, patient 7, if it's kind of a star-shaped, kind of irregular shape, you put more flow through, that can actually expand a little bit. So not everybody has the same degree of independence of flow. So that was sort of one of the things we realized in this exercise. We also wanted to look at aortic regurgitation. Our goal was ultimately to get to paravalvular leak and TAVR as a model. One of the things that this taught us is you have to be really sort of task-specific in these models. If your goal is to create AI, you need a more compliant ventricle. If you're not putting a device in it, you don't need it to be strong enough to hold back the radial force of a self-expanding valve. So this took a little bit of work to sort of figure out what material properties to get to. But ultimately, we had this compliant one. We had to have an imaging window. And at the end of the day, the echo quality that we could achieve looking through the model was excellent. But this is really a purpose-built model for this specific task. Kind of like the aortic stenosis I showed you, here's a comparison of the patient's echo. This is a continuous wave Doppler profile of aortic insufficiency. This is the color of aortic insufficiency. And this is the echo of that same patient's model. Basically showing that we did a reasonably good job of replicating the quality and the absolute velocities of the continuous Doppler and the color, and that they compare pretty well. So it's a completely different plumbing arrangement to look at systole for one case, diastole for another case. We learned that it's not easy to model both systole and diastole in the same model. You really have to be specific in what you're trying to achieve. But it's possible to replicate both stenosis and regurgitation for different patients. At the end of the day, we're trying to get to transcatheter valve modeling. These are many different devices. The Achilles heel still for this technology, these paravalvular leaks. In short axis, that's a paravalvular leak. That's the leak in long axis. That's the leak in 3D. So we wanted to get to basically a tabletop TAVR. So we want to take the model, do a transcatheter valve implant. That's what we've done in some of these models here. This is a CoreValve. It's a lot easier to do it on the tabletop than it is in the hybrid OR. And you put it in a similar way. This is a patient's echo that had a paravalvular leak in short axis and long axis. This is the same patient modeled from their CT, same valve, same size, same depth, relatively the same paravalvular leak. So it's not random. It really is driven by geometry and the issues of how you put in the valve, what size the valve is, how deep the valve goes. So we're really just creating sort of the ability to model this stuff, and that was an AHA-funded grant. So we're not the only people doing this. This is your slides courtesy of Manny Vannon at the Marcus Valve Institute in Piedmont. And they've worked with some people at Georgia Tech. They're doing kind of similar things now. They took 3D printed patient-specific aortas, but they included strain sensors. They just added a strain sensor, and then they do modeling. And you see that if you put a 23 millimeter core valve into this aorta, it's a fairly uniform strain pattern. If you stick a bigger core valve in, you start to get more strain. Not just strain, which would be predictable, but the strain is very focal. It's not uniformly distributed. It actually appears at certain spots. This is a case of one patient, very uniform strain pattern, no paravalvular leak. A different patient had a very focal strain pattern, and the paravalvular leak occurred right there. And in fact, ultimately, the model ruptured at that point. So this is soon to be published data, but sort of taking it another level. So what else can we ask with 3D printed models of specific patient geometry? And how does it impact the device-patient interaction? So let's talk for a minute about some procedural planning. This was a case a couple of years ago here at Methodist. This was a young lady who'd had a recurrent right atrial tumor, and it had to come out. She was symptomatic. Dr. Reardon and team looked at the CT and really tried to ask the question, where is this tumor attached? It had a big impact on the access to surgery. Is it a sternotomy? Do we go through the liver? Is it attached all the way down in the IVC? Do we bring in a liver surgeon at the time? How big an incision is made? So we 3D printed it, and right away you see that the attachment point was really very obvious. You could see exactly where it was attached once you had a 3D printed model. No matter how many times you sliced the 2D CT, it was really hard to find that or to be confident in it. So the surgery happened. The tumor came out. It was attached exactly where the 3D print said it was attached. The approach to the surgery was the right one because of the 3D print. It sort of guided that event. But one of the interesting things is that if you take the 3D print size of the tumor and you overlay the measures shown there in sort of transparent of how big the tumor was, they don't exactly line up. So one of the issues there, and one of the things we realize, is that the mass, when it comes out of the body, may look different than when it's pressurized and contained within a blood vessel. So that's sort of one of the explanations for this slight size discrepancy. This is another case, another young person. This is a tumor in the left atrium. So this is a recurrent osteosarcoma in the left. First time it had been resected, it involved the mitral valve. The mitral valve had been replaced with a mechanical valve. 2 years later, symptomatic CT shows this, and it appears to be tumor 1, tumor 2, and mechanical valve. This is another sort of display of the left atrium. So we split it with sort of a butterfly. So we're looking from the valve up into the left atrium. You see clear two distinct tumors that aren't connected to each other. One does involve the left superior pulmonary vein. And in fact, the mitral valve has tumor down into the valve. So we said, well, that's pretty complicated. We've never printed a valve before, a prosthetic valve. Let's see if this is at all helpful to have this three-dimensional structure. So again, we printed the LA clear, we printed the tumors color-coded, we printed the prosthetic valve below. And this is sort of a rudimentary representation of the prosthetic valve with the tumor inside. So in terms of deciding, is surgery doable, is it feasible, how should the approach be altered, where is the tumor attached to, it's valuable to have this sort of pre-procedural planning. This was a case of Dr. Lin, and this one I think is well known to many of us. That he's presented this case, his slides, and this is actually, I think, heavily featured in the annual report. But this is a young lady, congenital pulmonic issue, and really the issue of the plan was to do a transcatheter stent and valve in her pulmonary position. It wasn't sure it could be done. The entire surgical approach was altered after 3D printing and attempting the procedure up in the mighty hybrid OR. Ultimately, a very successful case with a completely different surgical approach based on the 3D planning. And I think this was an image that made its way into, sorry, shouldn't skip the team. One of the people I really have to call out here is Bill Dore Jr. He really is an advocate and very supportive of all the 3D printing we do. I'll mention him again at the end. But this young lady was very grateful and had a phenomenal outcome. So, again, we're not the only people doing these sorts of things. This was actually published in Circulation last week. This is a pretty straightforward case of a congenital ASD. This is the CT. The concern was that the rim was perhaps insufficient to do a transcatheter-based ASD repair. So the superior and inferior portion of the rim was missing. Sorry, the inferior and posterior portion of the rim appeared to be missing. So one of the real spin-offs of getting into this 3D printing is that you have to take a lot of time. You take the 2D data set, CT, MR, or echo. I shouldn't say 2D, the volumetric data set, but you have to look at it differently. You can't just look at it on a flat panel screen. So we're doing a lot more of sort of image processing and three-dimensional digital reconstruction, and sometimes we don't even need to do the print. You learn everything you need just from the digital reconstruction. So this is just a CT. It's sort of a flyby through the RA looking at this atrial defect. So that's the superior rim. That's the anterior rim near the aortic valve. And the camera just kind of pans down and looks at the inferior, and you see there really is no rim there. So it's just kind of flat. So a deficient rim, will a percutaneous ASC device work? Will it have sufficient sort of grasp? Well, and this is a case where you print the anatomy, you take the device, you pull it in there, and you tug on it. And you think, is it really sufficient? Is it going to grasp? And you can guess. You could do it in the cath lab, but it's, the thinking is it's safer to do it on a model ahead of time so you know exactly what's going to happen. And this was a case of a successful 3D print to guide this procedure. This is a case that's very active and one we're working on right now. This is quite a sick gentleman. He's 71 years old. He comes to clinic with NYHA Class 2 heart failure. His history is really quite complicated. He had an aortic dissection, endocarditis. 2 years ago at this institution, he had both a bioprosthetic and bioprosthetic aortic and mitral valve implanted, complicated hemorrhagic stroke, AFib, so all kinds of reasons that nobody's at all interested in going back in his chest. The echo and the T shows here a defect. And if you turn the color on, he's got this accelerated flow through his mitral valve and this accelerated flow, which is really effectively a primum ASD with predominant left to right shunt, but a little bit of right to left shunt. So all kinds of questions as well. We have technologies to close this, but how close will it be to his mitral valve? We can't occlude this valve. How close will it be to his tricuspid valve? In general, primum ASDs aren't generally repaired using transcatheter techniques because it's too close to the other important structures and you risk occluding them. This was his 3DT. It shows the bioprosthetic valve opening and closing well. There's a very low ASD that I showed you. In addition, there's a couple of very small paravalvular defects, one over here and one over here. They're almost pinpoint. And that becomes important in a second. So we 3D printed. We got a CT. We 3D printed this with the view of let's, as we've done before, practice a procedure and see are we going to be safe in terms of avoiding this prosthetic. So this is the mitral valve we're looking down on. We didn't print the entire prosthetic mitral valve. We printed a ring to represent what we were really trying to avoid. There is the ASD. And right here, there's a little pinhole, which at first I thought was an error in the printing. And then I went back and looked at the T. In fact, that's his paravalvular leak. The pinhole is real. He has a pinhole. The question was, could we put one of these, this particular one is a Gore helical occluder, through this device, block the hole, and not interfere with the mitral valve function. So this is circa yesterday. we went into Mighty. We took the model. With Panraj's help, and I saw Panraj walk in. He's really a wizard with the CT's data that comes out of this. We did this rotational imaging, and it really gives these fairly nice pictures of the model. So what we did is we put a plug through, and it shows the frame of the helical occluder, and said, is it going to be close enough? We wanted a tiny bit of overlap with the mitral surgical ring so that the ring itself would provide enough structural support so the device couldn't be pushed through into the RA. So this is a view from the LA, a view from the RA, and you see these little pinholes that appear even on the CT. Those line up exactly with the echo. I didn't show you that shows his paravalvular leak. So Avni Patel, who I saw walk in, spent a lot of time creating this model, and I'm pretty sure I never told her there was a paravalvular leak. But the CT knew it was there, and then the model made it. So this is a bit of wizardry that Panraj did. Let's see if I can get this to play. So this is sort of a flyby of the CT printed model before and after we put a plug in. And they're synchronized to sort of show the same thing. So you see this is a view from the right atrium. There's the defect. That's after we put a plug in. You can actually see down in here is the prosthetic aortic valve stent. There's the defect. Here's the surgical ring. And you see that it lays out very nicely. It has a little concavity. But when it achieves that configuration, it doesn't include at all the mitral valve. It just overlaps by a millimeter or two the annulus. So we're optimistic now that we can approach this patient. I think we have a solution. We have something we can try. We don't need to spend a couple hours in the cath lab sizing this device. We've already done the sizing. Let's just move forward and put it in. So this is sort of a stay tuned. As I said, this was yesterday, so patient being scheduled. But that's the plan, and that's one application of the modeling. So the other big area I want to get to is really sort of device innovation. How else are we using these models? So this is really a spectrum of all the devices that we've been hearing about for the last few years. So in the aortic space, really starting in 2002 with the Edwards valve, but now a very crowded market, many new players, Boston, Medtronic, Edwards, multiple different versions. In the mitral space, of course, we've got the mitral clip, all kinds of other devices, and a lot of interest now in transcatheter mitral valve total replacement, which is analogous to TAVR in the mitral position, and then all these left atrial occluders. So you can just see the timeline of what's happening. There's a lot of devices that are coming, a lot of catheter-based structural repair. And this is a case that we dealt with not too long ago, and which is sort of, I think it was instructional for us, but also somewhat motivational. So this was a 67-year-old, coronary disease, pulmonary hypertension, and really systemic level pressures, pulmonary peripheral vascular disease, cirrhosis, very sick. Refractory decompensated heart failure in the CCU for 4 weeks on pressors, really couldn't get off. Discussed this patient at our multidisciplinary valve conference. This was the main problem. A perforation through the base of the posterior mitral valve leaflet. Didn't have a clear history of endocarditis, but did say, yes, in retrospect, 6 months ago I had a febrile illness that went on for several weeks. So presumptive, looking back, had endocarditis, untreated at the time, no longer actively infected, but not an operable candidate with severe MR. This is the 3D. The arrow sort of shows this crater is really the location of this hole in your valve. So we said, well, this was 2 years ago now, let's think about, could we plug this with something? Dr. Barker and I had done a number of paravalvular leak repairs. We put plugs around prosthetic valves, never through the middle of a native valve. We didn't have a model. We identified a Canine heart that happened to be in somebody's lab in a freezer. I don't know how it got there, but there it was. They were happy to share it with us, and we basically made a hole that we thought was representative of the patient's hole, based on the imaging we had. And then it was sort of like, Goldilocks. We went through trying to try all these different devices. Which device would work? Here's one device. Profile was far too high. It would be too heavy. It would flop up and down within the left atrium. This is a different device, but the profile was too great below the valve, likely to interfere with chordae. Finally got to this device and said, well, this looks pretty flat and flush on the ventricular side. It's pretty flat and flush on the atrial side. This one will probably work. We did the procedure. There was the defect before, transseptal catheter, a plug position through the valve, significant reduction of MR. Patient had a very good hemodynamic response and actually was off pressors the next day, extubated, and went home. So we were impressed. We said, okay, this hasn't been done. Let's publish this. But let's not have to do this again, because at the same time, you know, we said, well, this may happen again. We don't have access to dog hearts to do this kind of planning. Around this time, Farouz Mahmood, who's CV anesthesia at Harvard, I think it's Beth Israel, he had published this, where he basically took a 3D TEE data set and just 3D printed the valve morphology and systole. So people were starting to do this stuff. We saw this, and I said, well, if this ever happens again, where we have a similar patient, forget the dog heart. Let's do a 3D print of their anatomy and see what we can fix. So we started to work on that. So this is a TEE mitral valve. And again, you have the digital data. You can decide, are you going to identify layers? So you can see the valve is rotating, but you don't have to print the valve all of one material. You can say, well, I want the outer layer to be this material, the inner layer to be this material. You're trying to recreate the material properties of tissue, which is not easy to do, but it's worth trying. So we sort of started to segment and print the leaflets. Then you said, well, that's not going to be good enough. We want to get more valve. So then you say, well, let's take the data, whatever data, whether it's a CT or a TE, to get the leaflet geometry, and perhaps even a different data set, which by echo you often have to have a different view to get the subvalvular apparatus, the cords, the paps, the ventricle. And Maria is here. I saw her walking somewhere. Many of you know her. She's a postdoc extraordinaire who works with us, and she does all this segmentation. She takes the leaflet data, blends it with the ventricular data, and now makes a three-dimensional reconstruction, a digital reconstruction to start off with, of the leaflets and the entire subvalvular apparatus, and then you can print it. So that started. This is acknowledging what's missing from that model is the cordi. The cordi are sort of the hardest thing so far. They're mobile, and they're very small. But we've started that effort, and we've talked to some potential collaborators up at Cornell in New York about helping us with this. And you can sort of see them readily enough on a CT, but that's a different level of material complexity in trying to print the cords. Nevertheless, we can get the mitral valve. You can identify from the ventricle all the calcification that exists and start to make it patient-specific. So far, we've done some pretty simplistic interventions like a mitral clip in the bench top, just to know that, yes, you can grab the leaflets, close the leaflets. The clip will actually hold on to the leaflets, and the material properties at least close enough to interact with the mitral clip in a relatively realistic way. But importantly, we wanted to, again, have this concept of, well, we don't want it to just look like a mitral valve. We want it to behave like a mitral valve, which means you have to have some effort to reproduce the leaflet material properties. So again, collaborating with the people at Rice and Dr. Randy Allen's lab, you do some basic testing. So leaflets to have bending tests, tensile tests where you stretch them. This is an example of, you take this little strip from a porcine leaflet. This is the same strip from a valve that we had printed, and you just compare the material properties. How close are you getting? So this is sort of a tensile modulus of an anterior leaflet, a posterior leaflet, and this is sort of different blends of materials trying to get closer and closer to the properties of in this case, a healthy mitral valve. And one of the important things is, again, here you have a porcine anterior leaflet. This is really just the stress-strain relationship. The more you strain, the greater the stress. Anterior leaflet, posterior leaflet, and a bunch of different materials. And these lines really diverge, and they get far away, and you think, well, we've really missed the mark. Not even close. But then if you look back at where physiology happens, it's down here in the toe. This is the range of real physiology in terms of the defined stresses. This is what you can expect to see in a living animal before you rip out the valve and pull it apart. And here, in this range, in the toe area, the correlations, not the correlations, but the comparison of the stress-strain relationship is actually much, much closer. So we feel pretty good about that. There's still a lot of work to be done, but in terms of an initial approximation of the material properties, it's getting better. So fast forward, this is a year from the last case of the person with the posterior leaflet perforation. Another one appeared. This gentleman from the Valley, endocarditis much more recently. He had wigglers under his mitral valve. We didn't want to mess around with a long procedure. He had a perforation and he had central MR. So he had two sources of MR, perforation and a central problem. We had this 3D printing experience now. We started on the mitral valve. We said, oh, well, this is the opportunity we sort of predicted would come. Here's his CT. Here's the echo of the perforation. We 3D printed his model here. This is a digital depiction of looking down on his mitral valve. The arrow shows the point of the perforation. This is the actual printed model, the perforation. The concept was to put a plug through here. And before I show the next slide, I brought his model. So I'll go the other way. And on this model, obviously, this is just the left ventricle, the aorta, and we actually have a little Amplatzer plug through the hole. We'll start with Dr. Winters. You've seen it, right? Okay, Sean, there you go. And the yellow is the calcification. So again, we met, and Dr. Barker and I sat down with the device reps and said, let's find a device that's going to work. Do we need one device, two devices? Importantly, we knew the device we used last time would lay out nice and flat on the atrial surface, but this particular patient had a lot of calcium up underneath the valve. So a lot of macular calcification, chordal calcification, a very lumpy, bumpy, irregular, ventricular surface of the mitral valve. And that was really the question, is would a device even lay out flat at all? So that's sort of a focused view, looking down on his left atrium. There's the perforation. A sizing chart said, well, let's go with this valve, or this device rather, at that size. That's what's going around the room right now, is the model with the plug. This was a zoom view from the ventricle, really trying to demonstrate that the device would lay reasonably flat despite all the calcium that was there. And then this was the procedure. Again, a transeptal approach. We've already put on a mitral clip. We've got a wire through the perforation. There's a clip and a plug. And a significant reduction of the MR. It went from severe to really, that's fairly mild. So we had this sort of blinking, and I looked at this for hours. And it's kind of mesmerizing, and I couldn't figure out why. And then again, depending how old you are, you'll... Am I right? Does it look like the dog? Okay, so that...
Smiling dog.
Smiling dog. It's a happy valve now. So that this was an application of 3D printing. So that's how we got there. So what's coming, of course, and we are very much involved in getting ready to do a transcatheter mitral valve replacement feasibility study, and then ideally a multi-year clinical pivotal study. And these are sort of the devices that are all circling the country and deciding where they're going to land. But basically, it's a catheter-based mitral valve replacement. They all have different approaches to anchoring within the ventricle, different shapes, different grabbers. They all intend to interact with the pathology in a different way. But, again, maybe one size doesn't fit all. And then you look at the CT and you look at all of the anatomic concerns. You've got, obviously, not just the size, but the aortic mitral angle, the septal thickness of the bulge here. None of these things actually show the subvalvular apparatus, the cords that nobody's taking out. They're all still going to be there. So in terms of understanding how each of these devices is going to interact in a specific patient, it's much, much more complicated than a TAVR. This is one figure from this excellent paper. It sort of gives you an idea of all these different devices. It doesn't show any of the valvular apparatus. So that's really an application of where 3D printing could be very valuable. You can print almost all of this. It doesn't need to be moving. It can be static. It can be systolic or diastolic. But once you've got it there, you can do benchtop TMVR and decide, are you going to occlude the LVOT? Are you going to hit the septum? Are you going to do all these things? So really 3D printing, just to sort of get to the summary here, there are opportunities, but there are still some challenges. This was a report about a week ago. The 3D printing, here we go, there's the headline, worth $30 billion by 2022. That's not all cardiovascular. So maybe Abbott's going to buy this one too, I don't know. But it's a huge market, there's a huge opportunity. It's hitting its way into cardiovascular now. It's already been in orthopedics and ENT for quite a while. The NIH is getting interested. They recently launched a 3D print exchange Within there's a heart library where people can actually upload their models or the digital version of their model. So far, I think all the uploads are by one guy because it's new. But there's a national interest in sharing these models, and that everybody doesn't have to necessarily make their own. One of the biggest challenges, the funding challenges going forward. So as yet, there's no data to influence payers to help pay for a model. We don't have data yet that says if you do this model, you have a shorter fluoro time, shorter hospital stay, or better outcome. It's hard to get all of that data from one center, but there's an interest nationally to create small trials to try to demonstrate that. We've had a philanthropic commitment to help out with these prints so far. Each model, the cheap one is $800, an expensive one is $3,000. On average, they're around $1,000 to $1,200 per model. So somebody has to pay for those. That's an issue. And I think we're almost at the point where we need to discuss sort of a service line business concept and almost develop like a 3D printing core lab. I gave a similar talk at MD Anderson a couple weeks ago, and all the questions were about how do we get 3D printing into our facility? Who's going to do it? We want this. Help us figure out how to get it done. So there's a huge opportunity to lead the field both locally and nationally, I think, in this area. So last slide, 3D anatomic models, they can certainly be patient-specific. They can be coupled to physiologic flow loops. They can provide a controlled and reproducible flow environment. They are a cheap arena, relatively, for mistakes and innovation. It's much better to make a mistake on a model than to do it during a procedure. They really allow for a gold standard quantitation of flow when you couple it to the lab. And I really think they're going to change how we practice and perfect structural heart innovations. So I have to acknowledge our team. Our team, as I've mentioned already, is Maria Vaskevich, who's I saw walk in, Avni Patel, Eleonora Avenatti, and Steve Igo locally. One of the neat things about this effort is we've really partnered with a huge variety of the faculty here. Imaging, valve, adult congenital heart failure, CV surgery. It's really been nice to work with a lot of different people. The foundation at Houston Methodist, Nan Duhan's done a lot of work to sort of get us support, and Bill Dorey Jr. has really been a pillar of support. He's provided a lot of these models for free for us. He runs a 3D Print Bureau of Texas, so we don't print these in-house. We print it at his facility in town. And obviously Rice University for the material properties has been very valuable. So I'll stop there and take some questions. Thank you.